Hello everyone, this is Yong-Suk Jo from Korea. I'm happy to have an opportunity to connect with the dentists from all around the world through this webinar. Today I want to present a topic, insight, concept and technique for immediate implant on mandibular molars. Insight is the ability to see the whole picture and penetrate to the heart of the matter. Great insight enables us to set the right goals. A concept is a compass that points us into the right direction. A sound concept shows us to the best path to achieve our goal. And technique is the tool that turns a goal into reality. The best technique solves problem with simplicity and precision. Optimal outcome in implant treatment can be achieved through exceptional insight, sound concept, and advanced technique. In this four-part online lecture series, I would like to share the insight, concept, and techniques I have developed through many years of clinical experience in implant dentistry. Today, it is immediate implant in mandibular molar, and next time, early, delayed, and late implant at mandibular molars. The third topic is insight, concept, and technique for maxillary anterior region. And the last topic will be insight, concept, and technique for maxillary posterior implant therapy. When is the best time of implant placement? After extraction. We place implant after tooth extraction. It depends on location of extraction site, bone condition of extraction site, and you can see the soft tissue condition, and sometimes we consider risk of anatomic structures. In reality, because of preference of dentist, we choose implant timing. Okay. Here is a classification of timing of implant surgery after extraction. Within 2 weeks, we call it is immediate implant placement. Under 3 months, early implant installation, and 3 to 6 months, we can say delayed implant placement, and over 6 months, it is late implant placement. By time pass, soft tissue will heal and hard tissue will be healed also. But when time pass, the volume will decrease. So you must consider everything. When is the best timing? Here is a patient who extracted left second molar, and in these pictures, soft tissue healed about 2 months later. However, the hard tissue, bone healing was visible after 4 months. So we need more time to heal the site, heal bony site. In this case, immediate implant placement is very popular. So many dentists have interest in how to place implant immediately. Okay, not only in mandible, also maxilla, anterior, posterior. What about the outcome of immediate implant placement? Many literature says that the success rate of immediate implant surgery is good, but there are also papers that says it is a little bit lower than late implant or delayed implant. In my experience, I feel that failure rate is a little higher when I do immediate implant surgery after extraction. So immediate implant surgery is very popular, but you must choose a good case to make more reliable outcome. When it is indicated, what is the key point for immediate implant placement in mandibular molars? Let me summarize key points. First, immediate implant placement in mandibular molar site is generally challenging. It is not always easy. When there is any concern regarding safety or predictability, wait at least 3 months. Before implant placement, wait sufficiently. A flapless approach is recommended whenever possible. If an endodontically treated tooth is expected to be difficult to extract, perform transradicular drilling before attempting extraction. Use a side cut drill, directing it obliquely from the medial root socket toward the septal bone. When bone quality is uncertain, underprep the osteotomy and assess primary stability during implant insertion. Consider diameter 4.5 implant first, but also prepare a 4.0 implant for immediate replacement. I prefer 4.5 implant as a primary diameter. Avoid too wide implant. Don't place ultra-wide implant during the immediate implant placement whenever possible. I don't recommend. If placement in the exact center is difficult, position the implant between the medial root socket and the septal bone and adjust the angulation slightly toward the distal side so that the implant is ultimately directed toward the center. The implant platform should generally be positioned at least 5 mm below the gingival margin. Generally, this is buccal facial gingival margin. Intra-socket bone grafting is usually unnecessary when it is a sound extraction socket. However, when the buccal bone wall is missing or significantly compromised, intra-socket bone grafting is recommended. What is the key point of immediate implant at the posterior mandible? There are 4 key points. First, case selection, and second, control over drills, and third, use of the depth gauge, and last, depth control. First, case selection. This is my classification of mandibular molar extraction socket. Type 1 is a sound extraction socket, and the type 2 is a pathologic socket. And in my clinical experience, very important thing is available apical bone height from the mandibular canal to root. When it is over 5 mm or more, it is A. It is under 5 mm, I said it is B. So here we can see 4 types of extraction socket at mandibular molars. This classification is based on safety and accuracy when placing implant. Especially safety is the most important. Depending on extraction socket, there are several treatment options. Okay, one is immediate implant placement without bone grafting. Second, immediate implant placement with intra-socket bone grafting. and immediate implant placement with GBR, and delayed or late implant placement without grafting or with the grafting. And one more thing is socket preservation and delayed implant placement. Okay, there are possible 6 kinds of option exist. Then, depending on type of extraction socket, which one is recommended? Here is a possible treatment option depending on extraction socket type. Type 1A, 1, 2, 3, 4 is possible. Type 1B, same, but my preference is yellow colored option. Okay, Type 1A, immediate implant placement without bone graft. Type 1B, I prefer delayed or late implant placement without grafting. Then what about Type 2 and Type 2A and Type 2B? It is generally delayed or late implant placement with or without grafting. Okay, this is my general recommendation. I said the key point, the key word for immediate implant placement. First is case selection. Then what is the indication of immediate implant placement? I think it is a Type 1A extraction socket. Although Type 1B and Type 2A is possible, but it is slightly risky. Look at this picture. Type 1A on the left top, Type 1A extraction socket. It is sound socket and available apical bone height is relatively sufficient. Even for beginners, it is better to delay the implant. It is easy and safe to place implant at exact position. However, if you want to do immediate implant, it is not so difficult. If you learn the tip to do immediate implant, it is not so risky, not so hard. So Type 1A is best indication for immediate implant placement. Then look at the Type 2B, lower left right side. Can you place implant immediately in Type 2B situation? Of course, it is impossible. It is impossible. Type 1B, when you place implant very carefully, and you are experienced dentist, you can do that. Okay, you can place implant like this. However, it is not easy, especially beginners who has less experience of immediate implant. It is highly risky. Our point is that we must place implant safely and accurately. Type 1B is not completely safe, and sometimes we make accidental problems such as nerve damage. So it is not good indication. We must be very careful. What about Type 2A extraction socket? When apical available bone height is more than 5, not just 5 millimeter, 7, 9, 10, very sufficient, we can place implant. However, when it is just 5 or 6 millimeter available apical bone height, what should you do? You must prep the osteotomy more than 3 millimeter to fix the implant. But in reality, it is very hard. It is very difficult. Okay? Drill stop does not function well at this situation. So accidentally, you may pass the mandibular canal. So it is also relative contraindication. So when it just considers safety and accuracy of implant, the best indication is Type 1A. And Type 2B is contraindication. And Type 1B, Type 2B, I think it is a relative contraindication. Second, control of drills. During the osteotomy, we have 2 techniques to control drill depths. One is with a stopper, another is with a tactile sense. When it is healed site or very strong septum exists, we can control depth of drill using drill stopper. But in case of immediate implant, especially when septal bone is very narrow or weak or very lowly positioned, we cannot use stopper as indicator. At that time, you must use tactile sense. Okay, with your tactile sense, you must control your drill. Many immediate implant case, you must focus on your sense and gradually advance drill with a controlled force. Of course, during this procedure, you must check the hole with the depth gauge alternatively. Okay, many cases I use depth gauge, drill, and carefully prepped osteotomy, and slightly progressively advanced the drill. And depth gauge is a really important tool to me when I place the implant, especially in case of immediate implant surgery. To check the drill depth, to check the bottom of drill hole, to check some vital structure, depth gauge is very useful, and you must use every time after drilling. Okay, one drill, one depth gauge is my rule. And the last key point is depth control of implant. What is the basic guideline of depth of bone level implant system? It is internal bone level implant system with a rigid correction. Here, I recommend you sync the bone level implant system watching the total soft tissue and hard tissue volume of the implant. It should be 4 mm plus alpha, and alpha is limited to 5 mm. Basically, I recommend you place implant minimum 4 mm from the soft tissue surface. Okay, so these are possible implant depths in such a bone level rigid connected implant system. Considering biologic widths, a depth of 3 mm may be possible as a minimum depth. However, in cases involving flap surgery, soft tissue recession must also be taken into account. And from a prosthetic perspective, 3 mm may not be sufficient in some cases. Therefore, I do not recommend 3 mm depths. For this reason, the minimum recommended depth is 4 mm. A depth of 4 mm or 5 mm is commonly selected for a routine implant placement. Okay. However, when it is immediate implant placement after extraction, I tend to place implant deeper, and I recommend a depth of 5 to 7 mm. 5 to 7 millimeter. 7, not bad. Generally, I place between 5 or 6 millimeter, but sometimes I place implant 7 millimeter. It's no problem. The depths of 8 millimeter or 9 millimeter are not intentionally planned, but may occur unexpectedly or unavoidably. Even in such a case, I consider them to be within the acceptable range, and the longest 9.0 millimeter healing abutment can be corrected. If the implant is placed deeper than 9 millimeter, it becomes problematic because no longer healing abutments are available. Okay, so in our focus immediate implant placement, try to place implant minimum 5 mm, watching from the facial, buccal, gingival margin, and 6 or 7 is also good depth. Here we can see the pictures immediate after implant installation. When time passes and soft tissue heal, we can see the height change. Okay, there is a resorption of tissue volume 0.5 to 1.5 millimeter. So average 1 millimeter bone tissue height will be decreased. Okay, so it's better to place implant not 4 millimeter in immediate implant surgery case. Minimum 5 millimeter I recommend. We can verify the depth of implant finally after connecting healing abutment. I like to connect 5 millimeter long healing abutment basically. Sometimes I connect 7 millimeter gingival height healing abutment. The left picture, when I connected 5 healing abutment, gingival height 5 millimeter, when exposed 1 millimeter, that means implant depth is 4 millimeter. I don't like this. It is insufficient depth. When it is just 5 millimeter, it's very sufficient depth, not bad. When it is 6 millimeter depth, it is sufficient depth. When we place implant, the gingival height at proximal side is much higher than the buccal side. Watch the buccal facial gingival margin. When buccal gingival margin is 5 millimeter, the proximal will be about 7 millimeter. Anyway, watching buccal and try to place implant about 5 millimeter minimum from the buccal gingival margin. Today, in my cases, I will show you Dentist XL implant. This is recently introduced in the market, and this is image of XL implant. It is 11-degree universal connection, internal connection, and it is tapered design with a deep thread. It features a deep thread with excellent self-tapping ability, allowing smooth insertion and reliable insert stability, even in situations such as immediate implant placement after extraction, or where available residual bone is limited and the apical bone is dense. This situation, you can utilize the advantage of this implant system. And it has a variable thread design. Through its variable thread design, the implant is less dependent on drilling protocol and enables a smooth placement with a stable initial fixation. Okay. During the drilling, I don't try precise drilling. Okay. Just rough drilling is possible, but this implant is easy to place and even the situation is stable. Let me show several cases of this implant. It is mandibular molar site and all are immediate implant placement after extraction. Here is a 38 years old male patient who complained of the mobility of right second molar. Second molar implant. Okay, patient received the implant 2 years back at other dental clinic. Just 2 years later, patient said, for the chewing, I feel uncomfortable. Okay, here we can see long implant placed a little bit distally positioned, a little bit too much medially tilted. And in panoramic view, some radiolucency is visible around the implant. This is intraoral situation. Okay, implant crown is visible at the right second molar site. In the radiographic image, here we can see the radiolucent line around the implant. That means it is failure of osseointegration. Then what should I do in this case? I decide to remove the implant, and if possible, I will immediately place another implant near the site. In such a situation, I must prep the osteotomy a little bit slightly more anteriorly, and I want to get primary stability. Here, implant was removed. Removing implant was very easy, and I cleaned the site with curette. Then, slightly more medial site, I prepped osteotomy with a drill. And then my last drill was 4.5 by 40 millimeter long drill. Then I selected the XL 4.6 by 9.5. Okay, it was placed with a good direction, and I can get 80 Newton centimeter and ISQ value 84, 83. The bone was relatively dense. I worried about displacement of implant toward the distal side, but it doesn't happen. I can keep the position as I prepped osteotomy, implant inserted smoothly through the osteotomy site. And I connected the 5 of 5 healing abutment and took X-ray radiographic image like this. Here, panoramic view and periapical radiographic image. Although the position looks not bad, look at the distal side. Because I removed the implant, distal side there's no bone, and bone will heal spontaneously. However, I worry about the slightly less bone will slightly reduced, and worry about exposure of 1 or 2 threads at distal side. So I decide to control depth of this implant. Look at the apical portion of the implant. There are some more available bone I prepped already. So just simply connected the implant driver and advanced the implant. The torque was increased further to 90 Newton centimeter. Although it is relatively higher insertion torque, I don't worry about pressure necrosis actually. There are terminology about pressure necrosis, so many companies recommend control the insertion torque under 40 or 50 Newton centimeter. I don't agree about that. Even it is higher than 90 Newton centimeter. I carefully advance and usually it doesn't make problem. Anyway, insertion torque is very nice, so I can finish with one stage the surgery. After depth control, now I satisfied about the depth of that implant. Okay. Such a excellent self-tapping capability demonstrates its full potential in immediate implant placement after tooth extraction. Okay. So in following cases, I will show you immediate implant cases. Okay, here is a 39 years old female patient who experienced the crown fracture of number 37 and 46. Okay. In intraoral clinical photo, we can see the severely decayed crown of left second molar and right mandibular first molar. So I planned the extraction and immediate at that site. In panoramic radiographic image, look at the mandibular canal. Okay, let's trace mandibular canal. Okay, like this. The mandibular canal is far away from the root, so they belong to type 1A extraction socket. It is sound and sufficient available apical bone height. So this is the best indication of immediate implant placement after extraction. This is periapical view. First molar is endodontic treated tooth, so I must extract very carefully. Okay, it is all. Okay. In this radiograph image, left side, your right picture. It is type 1B extraction socket. Let me back. Sorry. Okay. Okay, it is not type 1A. The 46 is type 1A. 37 is type 1B extraction socket. It is very near the mandibular canal. Generally, in such a type 1B case, it is not safe if you are beginner, better to choose a delayed implant installation. But I have many experience and I can do that, so I tried immediate implant. It is conical shaped root. That means during the osteotomy, your drill stopper is useless. So you must use very careful, controlled force with up and down motion, rely on your tactile sense. Okay. And one more thing is that when you prep osteotomy at last mandibular molar, how long drill you have to use. Okay. Generally, we can say that better to use short drill to avoid nerve damage. However, when we use short drill at this site, it is troublesome because such a short drill very frequently makes trouble during the advancement. The anterior first molar will touch on a shank of handpiece. As a result, you cannot keep the good mesial angulation. Instead of short drill, I prefer using relatively long drill because long drill can avoid the interference from anterior tooth, and I can see the direction very well when I use long drill. Just one thing you must keep in mind is you have to use very careful controlled drilling. Okay, here is my drill. It is my last drill was 4.5 by 14 millimeter long drill. Okay, it is long drill. With this drill, I carefully prepped osteotomy, but it is near the mandibular canal. I just advanced drill slightly deep, about 2 millimeter or 3 millimeter from the apex. Okay, so prep the hole looks like that. Okay, slightly mesially and slightly advanced. After finish osteotomy, I check the depth of osteotomy hole. Okay, this process is really important when you do immediate implant placement. How long implant you gonna place during the immediate implant surgery? Think about the final depth of implant. My implant must be positioned minimum 5 mm from the buccal gingival margin. So, checking depth of osteotomy site and check the depth of hole. In this case, the depth was 15.0 millimeter. Then, that means available length is 15 minus 5 equal 10 millimeter. Okay? Why I minus 5 millimeter? Okay, I want to place implant minimum 5 millimeter. That's why it's my formula to select implant length. So 10 millimeters available length. then you must choose implant less than say 10 or less than 10 millimeter. Okay, the short is better. No, don't place longer than this. Okay, here I selected the SQ. This is dentist older version. SQ implant 4.5 by 9.5 millimeter. Okay, I tried to place implant in here. Okay, like this. However, I couldn't get primary stability with the SQ implant. SQ is generally acceptable in general clinical situation. However, I sometimes feel trouble in such a special situation. When apical bone is not so much, I prep the small portion and try to anchor the implant. It sometimes spin. I couldn't get prime stability. So here I change the implant to XL X thread. Okay, it is new one, and the thread is really sharp, really sharp. Look at the comparison of XL, regular XL thread and XL X thread. X thread has a deeper pin. Okay, the body is the same. The body is same. However, the pin is wider. So it is same as regular XL 5 millimeter. So here I select the middle one. By changing to XL X thread, I can get strong prime stability, 70 Newton centimeter, and the ISQ value was 69. Okay. After implant installation, I connected the 555 healing abutment. The diameter 5.5 and gingival height 5 millimeter. This is my favorable healing abutment at molar site. In premolar site, I connect the 455, diameter 4.5, gingival height 5 millimeter. And this is the end of the surgery. Okay, it is sound, extending socket, and after connecting healing abutment, I finished the surgery. On the right side, sectioning first molar and extracted. Okay, after extraction, prepped osteotomy carefully. In this case, I tried the transradicular osteotomy for extraction. I couldn't extract easily. It is endodontic treated tooth, so without extracting the root, I advanced the drill between root. Okay. After finish drilling, okay, sorry, maybe I extracted first and then prepped osteotomy center. Here I prepped the previous implant, which failed to get prime stability on the left side. It is SQ 4.5 by 9.5 millimeter. I placed the implant in here. In this case, I can get strong primary stability. So, finished simply, same as left side. Just corrected healing abutment and finished. Okay, the videos are available. Video is available. So watch video, please. First, I try the left side. Extraction was finished. And I preparing osteotomy about 5 millimeter distal from the number 6. It is not center of extraction site, slightly medially tilted. And I'm using long drill, 40 millimeter long drill to avoid interference. And during the osteotomy, I carefully check the condition of a hole with the depth gauge. Okay, gradually advanced with my tactile sense. 4.0 and the last drill 4.5. Again, check the condition. Okay, then I selected a 4.5 by 9.5 SQ implant. I advanced, but I couldn't get primary stability. I decided to change implant to XL implant. XL implant has a strong self-tapping ability, so I can get nice primary stability with the XL implant. Torque was really high. Depth more than 5 millimeter. Pass controlled watching posing number 7. Here I corrected the healing abutment and finished the surgery. Okay, finished left side. Then let's move to right side. We need a sectioning, tooth sectioning for extraction. After sectioning, I will use fine elevators. In these days, when it is endodontic treated tooth, I prefer luxate elevator, not routine root elevator. I like to use luxate elevator. It is very thin blade. It has very thin blade and strong, so easy to extract such a root remnant. Okay, like this, medial and distal root. Okay, again I section the distal root once more. Okay, successfully extracted the tooth. And the prepped osteotomy, enlarge the hole gradually. For 4.0, 4.5. Okay, it was normal bone density. After drilling, finally check the condition of hole and the depth of hole. It was previous implant which failed to get primary stability on left side, but this time I can get enough stability with the SQ implant. ISQ value was good and connected healing abutment. Okay, surgery finished. This is POP, panoramic and peripheral view. Everything looks good. Implant well positioned, and implant every implant has strong stability. Here, 5 weeks after the surgery, soft tissue healing condition was very nice, and the ISQ value was not bad. When you start loading, here is a device to check ISQ value from Austell, and the company says when the ISQ value exceeds 72, we can start loading. For safety, generally, I start loading when ISQ value exceeds 75. The price of Austell device is really expensive. That's main obstacle using Austell. And recently, dentists introduced the CheckQ, which provides the same implant stability measurement function as Austell, while being designed for great ease of use. it is also competitive priced, competitively priced. Okay, so I highly recommend this device to many clinicians. I always check ISQ value just after surgery, during follow-up, and decide when to load. The ISQ value is really high because patient didn't want early starting. It was slightly delayed. Anyway, at the time, 4 months later, ISQ value is 89, 91 on the right side, and left side 85, 84. It's very strong stability. So my prosthodontic partner, Dr. Kim, started loading. Okay, he used the stock abutment in this case, selected the color and the diameter and height. By scanning process, final definitive restoration was fabricated. Okay, it was cemented in patient mouse on lab analog. Sometimes cemented on patient mouse, sometimes using lab analog. Here is final outcome. Okay, crown delivered successfully and finished. It's very short follow-up, 2 months and 3 weeks after delivering the final restoration. Okay, so this looks healthy in condition, and also it is increasing the radial density around the implant. And the profile looks not bad. It is deeply placed. In summary, here, it is immediate implant placement case. Bone was not bad. So I can get a strong primary stability and finish the restoration. Okay, next case. It is 46 immediate implant case. Patient complained of severe tooth pain when bite food. Okay, right mandibular first molar has very long root. In the radiographic image, you cannot see any special finding. We suspicious about the crack of tooth. So first try the crown. However, patient continued discomfort. Root canal treatment was done, but symptom persist. So decide to extract the tooth. Okay, he is a 48 years old male patient, and in normal occlusion. Okay. To extract the tooth, this time I used the cow horn forceps, but unluckily the roots are fractured. Extracting such a root remnant is always challenging. There are several strategies to extract such a root. One is using a fine instrument, such as luxate elevator. Luxate is really nice. And the second strategy is transradicular drilling, like this. Without extracting root, prepped osteotomy and at ideal position. Okay. Here, I used the 4x 40 millimeter long drill, and transradicular drilling was finished. After drilling, try to extract the root. Sometimes you can very easily remove the root. However, in some cases, even after transradicular drilling, still it is difficult. At this situation, try to guttering around the root with a needle diamond burr, very narrow, long diamond burr. Guttering can be performed. After this, try to extract tooth. Patient has 3 rooted condition. Okay, distal lingual root was present, so it was hard to extract. Anyway, finally, After extraction, I prepped osteotomy with a 12 mm long drill. Okay, finally it's 4.5 by 12 mm long drill. And after finish osteotomy, again measure the depth of a hole. The depth was about 16 millimeter. 16 millimeter is a deep hole. Then what kinds of implant, how long implant can we place? Available height is 11 millimeter. At that time, I have 9.5 millimeter long healing but the implant which is available. It was early case. The option was not sufficient. So here I selected a 9.5 millimeter long XL implant, diameter 4.5 millimeter. Okay. Then I can get strong primary stability, 40 Newton centimeter, 84.79. And the position of implant looks also nice because I performed osteotomy before drilling, okay, with a transradicular drilling. The position is well fixed at center. After extraction, it is not easy in reality. 5 of 5 healing abutment was connected. Here, POP, radiograph image shown ideal implant position and the path. In this case, it is exactly in the center. However, this is not always possible, and it is not always necessary to place implant exact center of extraction socket. There are two situations when we can place implant at the center of the socket. Generally, this inside the septum, we can keep the path watching adjacent teeth and bisecting path is ideal. Anyway, the hole is at the center. But sometimes we cannot put implant at exact center of the extraction socket. That situation, position implant between septal bone and the medial root and get stability. Then minor path change is necessary to aim the hole at center. That means you must tilt slightly distally. Actually, this is not distal tilting. Okay, we reduce the medial tilting slightly, then hole will be aimed toward the center. Okay, many cases I do implant like right side, not left side, because placing implant exact center is not easy because of resistance of the interradicular septum. So we need a special tool such as trephine bar or special drill to position implant exact center. But it is not necessary. Okay, even we place implant slight medially, okay, correct the path slightly and aim hole center, that's really acceptable in many clinical situations. So many cases I prefer right side. Okay, like this. The drilling tip is when we extracted the first molar, generally septum exists at center. It is not strong generally. It is very weak and narrowed septum. So positioning the drill at the exact center of socket is not easy. Instead, the Lindemann drill is initially positioned against the septal bone from the medial root socket, okay, and advanced obliquely toward the center of the extraction socket. Okay, you must push the drill bodily. Do not tilt distally. Okay, just move bodily toward the center. The subsequent drill are used in the same manner. Finally, implant will be placed like this. It is not exact center of the number 6 extraction socket. Basically, its base is between septal bone and medial root, but general, the direction is toward the center. It's very useful method to place first molar implant. 에어컨 좀 켜줘. Okay, look at the video. Here I try the extraction, and then I position the side drill medial of the septal bone and push toward the center. Distal root was extracted with after the guttering. After drilling, I extracted the teeth, tooth roots. And the final drill was used. Here, XL implant was placed. Carefully control depth of implant. And I checked the ISQ value with the check Q. 79, very nice. Connected healing abutment. Okay, implant well positioned. Again, in this case, I didn't correct the bone around the implant, just finished. 1 week after the implant placement, we can see nice soft tissue healing. It contracted well and no sign of inflammation. 5 weeks later, ISQ value increased to 86, 83. Okay, it's very nice ISQ value and healed soft tissue, so we can start loading at that time. Dr. Kim fabricated definite restoration with a customized abutment. Okay. Here, customized abutment with a full zirconia crown was fabricated. It was delivered to a patient. Okay. So very simple and early, the case finished. It's summary of this case. Okay, immediate implant was done using a standard protocol, drilling protocol, because it was normal bone and everything was smooth sailing. I can get strong primary stability, and also healing was very nice. We can finish the restoration 2 months and 2 weeks after implant surgery. Okay. Next case is second molar case. The patient was 49 years old, female patient who complained of the discomfort of left and right mandibular last molar. Look at the panoramic image. We can see the secondary carriers of second molar in both mandible. Okay. And the mandibular canal was traced like this. Okay. So when we see the mandibular canal and the roots, it is type 1A extraction socket. In this case, the prognosis of root canal treatment followed by crown restoration was explained to patient. Okay. Along with the advantages and disadvantages of extraction and immediate implant placement. After considering both options, this patient choose implant treatment. In Korea, the price of implant is not so expensive, so patient has no much burden about implant therapy. Okay. Here, clinical views. Okay. In the periapical view. Okay. In periapical view, it is slightly lowly positioned carious margin. We can do crown with endodontic treatment, and if necessary, crown lengthening is possible. But in Korea, less burden about implant, and patient wanna more predictable longevity implant they prefer. Okay, left third molar and the second molar was extracted. After extraction, routine drilling was done. This time, I used the drill extension to prep the osteotomy. When patient can open widely, even it is 7, I use extension. Short drill cannot see the path well, and it arises frequently interference from number 6. Okay, to keep path well, I used a very long drill, and then 4.6 by 9.5 millimeter XL implant was placed. Checking position, path carefully, and then finish. Okay. The insertion torque was 13 Newton centimeter, and ISQ value was 82, 81. So it's nice. It's nice stability. And again, I corrected the healing abutment, 5 by 5 healing abutment, and approximated the flap slightly, very lightly. Then extracted right second and third molar. Carefully prepped osteotomy again, and last drill F4.0 by 12 millimeter set drill. Even in the same patient, it is split mouth situation, very similar situation, but bone density is different depending on location by location. I felt a slight soft bone density, so I tried under preparation on the right side. After under preparation, place the same size, the same length implant. Okay. Here, torque was good, 60 Newton centimeter. Also, ISQ value was enough high. Connect, healing abutment, and finished. Okay. It's my routine job when I have such a relatively simple case, a sound socket, and the surrounding wall is sound. Generally, I finish like this. Okay? Look at the video of this case. Extracting 7 first. Simply extracted. Then extracting third molar is also very easy. I pursue clean surgery. So keep surgical field well using adequate retractors. And no need to elevate the flap in such cases. Carefully advance drill with my tactile sense. Check condition of bottom, whole bottom. It is solid. Then enlarge to 3.5 drill. One more check. Okay, one drill, one depth gauge. 4.0 drill was used. Okay, make sure about the paths and the depths. I use the extension at short time. And here is XL implanter. Basically, this no mount system. And recently, I decided to use mount system, and I request to R&D center of dentist and made implant mount. Mount is useful to check the path of implant and the depth of implant, position of implant. Everything is useful if a mount is available. Okay, because of extraction site of number 38, I decided to approximate flap. Generally, this is not always necessary. Simply approximate with the 5-0 nylon. When it is left molar site, I positioned at 11 o'clock over the patient. Okay, and when it is right side, I position 9 to 8 o'clock. Here, extraction was done. It was a sound socket. Again, I positioned the drill, side drill, at the medial side of the septum and pushed toward distally. Carefully advance and enlarge the hole. Okay. Checking bone density and gradually advance drill. When it looks soft, try under preparation. Watching laser marking system in the implant driver. The last laser marking means 5 and 4 millimeter. So usually I place implant 5 millimeter. Watching laser marking. I-sq value very nice. So I connected healing abutment. Okay, slightly medially positioned. Again, approximated flap with a 5-0 nylon. If question is, if you have any question, you can. Okay, there are several questions already. Already there are several questions in English and Korean. Here 두 개 있나 이게 채팅창이? 하나 영어고 하나.
하나는 OF 채널이고 하나는 덴티스트 채널.
Okay, there are two channel for question. Okay. Okay, this is POP. Okay, after this case, I will give some answer about question. Okay, well-placed implant. Although right side, I found the path looks too lingually tilted. In case of number 7 implant, carefully watch the opposing tooth. When opposing tooth tilted or elongated, depending on the option, you do end crown or just do enamelloplasty, you must aim the lower implant axis toward the opposing tooth. This case, I decided to tilt slight backally, so simply control the pass. Again, here radiograph image. Okay. 1 week later, healing looks very fast and good. 1 month later, nice ISQ value and almost healed. It requires about 2 months for soft tissue healing and start loading. Okay. With a stock abutment, Dr. Kim fabricated crowns, okay, with a digital process. Okay. If possible, Dr. Kim, my prosthodontic partner, can explain about the restorative procedure, next time or another webinar. Okay, finally, here crown and implant crowns are made and cemented on the lab analog. When test of position is good, we can cement the crown on lab analog. Final outcome is here. Right second molar and the left second molar. Okay, like this. XL is recently introduced, so follow-up is not so long. It is 9 months and 1 week after final restoration, clinically good in soft tissue condition and the bone condition. Same on the left side. Okay, nice bone response and soft tissue response. So case finished like this. Okay, there are several questions from audience. One Korean dentist asked me, what about the bone compaction kit, such as Densa, Burr, or other company? Compaction kit, maybe it is useful to increase the density in case of soft bone. But there are some controversy about densification. We don't know the intentional compaction has a negative effect or positive effect on bone healing. We primarily can see the advantage of increase just the primary stability, but it is not always a positive effect on healing. And only it is useful in case of D3 or D2 bone. Especially D3 bone looks a favorable condition to maximize the bone compaction effect. D4 bone, it is not possible. So Densaba advertise their ability to get prime stability. I do just under preparation instead of compaction, but the result is similar. Okay. Okay. Another question is, I had a nice prime stability and ISQ. Why I waited 4 months? Well, it depend on patient condition actually. Generally, when ISQ value is very nice, about 2 months after the implant installation, Dr. Kim start the prosthodontic process, because he wants to make a good definite margin watching soft tissue healing. So it requires about 2 months healing for soft tissue. So about 2 months later, we start restoration. But sometimes because of patient condition, we have to delay the prosthodontic process. Another question. I said avoid the ultra-wide implant. What about what should you do when you try to place implant 5 mm and you couldn't get prime stability? What should you do? He said the question maybe he said at that situation you can immediately replace to ultra-wide. Maybe possible. That's possible. But what is the disadvantage of ultra-wide implant? It is less tolerance of problem solving. When ultra-wide implant was placed and it never make problem, it's okay. But we don't know what will happen in the future. Okay, so I always put ultra-wide implant as a rescue diameter. So my basic principle is the primary diameter implant is most short, the shortest diameter, means smallest diameter which does not fracture. That's my basic principle. So I feel at the molar single or multiple, my primary diameter 4.5, not 5 millimeter. Because when 4.5 implant lost some stability during the implant installation, I can immediately change to 5 millimeter. However, when I tried 5 millimeter at first, I have to use another ultra-wide implant. I don't like it. I don't like this situation. That's why I like 4.5 implant as a primary diameter. There are some issue about implant fracture in single molar site when it is 4.5 implant, but issue is limited. Okay, and when I place the dentist implant 4.5 implant, I have no experience of implant fracture. Okay, and one more thing. If you fail to get prime stability during the immediate implant, don't worry about this. Just connect the cover screw instead of healing abutment. That's more easy and simple solution. Okay, here's another board from English question here. Can immediate implant be predictably placed in site with a chronic periapical infection? And what protocol do you follow to minimize failure? Okay, I don't worry about infection itself, especially this chronic condition. When we extract the tooth and clean the extraction socket with a surgical curette mechanically, it's enough to control infection. Generally, it is surrounded by soft tissue or granulation tissue. When it successfully remove that tissue, it is in clean condition, I think. And my contraindication is when it is risky to place implant, such as possibility of nerve damage, that's contraindication. Infection itself is not absolute contraindication, or even me, I don't care about this. Okay, some dentists like to clean socket with a antibiotic powder or solution, or another dentist like to peel off the bone around the extraction socket. I don't do that. I feel it is not necessary. Okay, it's my experience. Another question: if you have any okay, this is not this one. Should we place implant in socket or in the radicular bone? Yes, it's possible. It's possible. In case of premolar site, you can place implant utilizing the socket itself. Premolar is not round shape. It is slender mesiodistally. So when available bone height is not so much, we can anchor the implant inside the socket. However, molar site basically just placing mesial root or distal root exactly is not so ideal. Instead, better to grind the septal bone slightly from the mesial to septal bone. Then it is between the mesial root and the septal bone. Then that's acceptable. Not at center of the mesial root. It is between septal bone to mesial root. Favorably more distal to septal side, septal bone side. Anything is possible. Was it not also integrated that you removed the that implant failed osseointegration? I don't know exactly why, because I didn't place the implant. During the functioning, maybe it failed osseointegration. It is too far away and too much mesial tilted. As a result, the cantilever loading made a failure of osseointegration, I think. Here's Korean question. in my video, I determine drill length before osteotomy. Okay, this is a question about the relation between the drill depths and drilling. Actually, there's no relationship between drill length and the implant length you will place. It is no relationship. I use convenient drill, which can prep osteotomy conveniently and safely. Okay. Generally, I like to use long drill. For example, in immediate case, I like to use 12 millimeter or 14 millimeter long drill, and control depths of hole by gradual grinding, okay, with controlled force. After finish osteotomy, I insert the depth gauge to check the total depth of hole. And with the formula -5 millimeter, I have a available height, and then select the implant length less than that available height. That's my tip. He asked me, with the CT view, it is difficult to check the bone height. Maybe that's true. Just with a radiographic image, we don't know how much deep drill we can prep. My point is safely prepped osteotomy, and the most important is depth gauge during the osteotomy. When I can feel the hardness of flow, it is always safe. Don't try to prep the osteotomy too deep. Okay, when you cannot prep the osteotomy too deep, it's okay. Okay, when the total depth, the hole is not so deep, we can use a short implant, such as a 7 millimeter, even extra short implant. It is 6, 5, even 4 millimeter. Okay. Purpose of drilling is prep osteotomy safely, and then finally select implant length depending on your preparation. That's my strategy. Okay, one question is difficult to get prime stability. If you are a beginner, yes, it is not always possible. And because you didn't prep osteotomy exactly, actually, if you're a beginner. And one more thing is that some beginner has the troublesome during the evaluation of bone density. When you are a beginner and we have no confidence about bone density, under preparation, try to place an implant. When you cannot advance, prep more large drill. Okay, you need some trial and errors. Do we need bone graft if stability doesn't achieve the minimum requirement? Possible, but I don't recommend that method. Instead, if you cannot get the prime stability, okay, basically when it is more than 15 Newton centimeter, I connect healing abutment. It's my recommendation. When it is under 15 Newton centimeter, just connect the cover screw. That's much easier way. Okay, don't try to replace another large implant. That's the second choice. My recommendation: if you fail to get stability, just connect cover screw and perform second stage surgery later. Okay. Is there any way to boost the healing of soft tissue time? Maybe using vitamin or measure? Any measure needed? Well, when patient is in healthy condition, the healing speed is not bad. About 2 months later, it will heal. Okay, except any general problems such as diabetes or severe osteoporosis, I don't worry about healing time. Is actually vitamin does not accelerate the healing time, I think. So patient is in healthy condition, no need any special way to accelerate the loading time. 2 months looks enough. Don't see any bone grafting material on scan. Okay, you didn't see the bone grafting in my previous cases. I didn't graft any graft material because every case was in type 1 sound extraction socket. At that situation, it is a self-contained defect. It is surrounded by sound bone. In such a self-contained defect, the bone graft is not mandatory. It heals well. That's why omitted bone grafting. In the following my case, I can show you some grafting case. Is it true immediate case always? Is it true immediate case always need to place the implant more lingually to reach more bone surrounding implant? Okay, no, not really. When it is, it depends on anatomic condition of the root. Okay, think about the position of root in immediate case. If it is premolar case, you must place implant lingually. Actually, it is not lingual. It is center of the alveolar bone because natural tooth root is positioned the buccal side. You must aim the lingual slope of the extracted premolar. Then it is center of the alveolar ridge. Anyway, it is lingually placed implant. But think about the molar side. The position of molar root is the center of alveolar bone. So just aim center. Okay, no need lingually placed. Okay, in mandibular molar case. Okay, I'll continue. Here is 46 immediate implant case. Because of this discomfort of first molar and which has a fistula. Okay, it looks like this. Okay, on this panoramic radiography, tooth 46 had undergone root canal treatment and was restored with a crown. A radiographic region, a radio-opaque region is observed in the medial root area. Maybe it is fracture of root. Okay, this is type 2 extraction socket. However, immediate placement is not particularly risky because sufficient residual bone remains apically. So I can do immediate implant, even this is type 2 case. In the right mandibular first molar, it's shown 3 roots. Okay, so you must care to extract the root. We can see the fistula on buccal side. Again, I tried to use Cowan forceps, but just crown and medial root was extracted. Distal roots, this lingual, this buccal was fractured. Okay. Here I tried osteotomy with a 10 millimeter drill and extracted the distal roots. Okay. Then this is the after extraction. I prepped osteotomy at center, and that time XL X-thread 5 by 9.5 millimeter was available, so I placed this implant. I can get enough prime stability, and here I found the loss of buccal bone. Okay, because of inflammation, buccal bone was lost. So in this case, I tried intra-socket bone grafting on buccal side. It was a xenograft. After bone grafting, corrected the healing abutment and finished the surgery. Okay, it is panoramic image after surgery and the periapical view here. implant positioned very well. 1 week later, healing was not bad. 1 month later, IHC value maintained highly. So 6 weeks after the implant, soft tissue looks almost healed. Dr. Kim started prosthetic procedure and using a stock abutment, continued restoration like this. Okay, it's a final outcome here. In soft tissue view, slightly reduced buccal bone, however, buccal bone volume, but because of grafting, is relatively well maintained. Okay, so this is summary of this case. As questioned me, I do graft sometimes when buccal bone is lost. This is also type 2 case here. 47 tooth was mobile and patient complained about this. Well, this is not this case. This is also type 2 extraction socket and with only 5 mm, approximate 5 mm available bone. It is not each case for immediate implant for beginners. Okay. One more thing is that look at the density of bone. In this periapical view, it is D1 bone density because of reaction from inflammation. It happened. Okay, it's really dense bone. Available bone height around 5 mm, and apical bones very dense. Drilling in this situation where the bone height is limited and the bone is dense, it is technically difficult and can sometimes be risky, okay? Because accidentally we can pass the mandibular canal. We must press down with considerable high pressure, but because of stopper which does not function well, the chance of penetrate the mandibular canal. So drill must be advanced very carefully and gradually, little by little, based on your tactile sense. So technically it is not easy. So it is not recommended for beginners. Okay, 47 was extracted. And again, I used the long drill, 4.5 by 12 millimeter drill, and gradually prepped osteotomy. You need a sharp drill, and on depth gauge, you must prep the apical portion about the 3 millimeter more than 2 millimeter. 3 millimeter apical preparation should be definitely prepped to anchor the implant. The total depth of this case, this osteotomy site was 13 millimeter. Then, how long implant you can place? Let's think about the available height. It is 8 millimeter. Okay, 13 minus 5 is 8 millimeter. So, in such a situation, I selected a 7.5 millimeter XL implant. During the insertion, it spinned. That's because I didn't prep the sufficient long apical portion. It is under 3 millimeter. So it again spinned. So I decided to advance further, changing drill to 14 millimeter long. Okay. And I checked the hole depth again. Now it is 14 millimeter deep hole. Then 9 millimeter is available. Then what should you do? If you have a 8.5 implant, you can place implant. But that time I have no 8.5 implant. 9.5 available, 7.5 available. Then what should you do? Better to place a short one. Okay, XL 4.6 by 7.5. Deeper installation is allowed. However, shallow installation is not allowed. Okay. Now I can get strong, enough, not strong, it is enough stability to connect the healing abutment. 19 Newton centimeter, 61, 61. Okay. It is slightly deeply placed, more than 5 millimeter deep from the buccal gingival margin. Look at the video. Okay, as you see in this video, I feel some trouble advancing drill because the apical bone was really dense. I move the depth gauge when I didn't prep the sufficient depth, I couldn't get prime stability. At first try, I couldn't get prime stability because I didn't prep the apical portion about more than, I need more than 3 millimeter preparation, but it was less than 3 millimeter, about 2 millimeter. As a result, I couldn't get prime stability. At another preparation, I couldn't get prime stability. Here, failed to get prime stability. With another long drill, continued osteotomy. You must be very careful not to hit the bone. Hitting arise in case of hard bone. Same implant was placed. Now, not bad. Okay, depth enough, pass good. Check the ISQ value with the CheckQ device. And connected the healing abutment. Okay, surgery finished. Okay, this is POP radiograph image. Enough deeply placed. 2 weeks later, healing looks uneventful. And 7 weeks after the operation, look at the soft tissue condition. It is almost healed. This is stuck abutment with the zirconia crown. Okay, it was cemented in patient mouth and finished the crown. Okay. 3 months later, follow-up clinical photo and radiograph image was taken. Okay, soft tissue healing condition is very nice. There's no definitive bone remodeling yet. It requires about 1 year to see the remodeling of cortical area. Okay, this case was apical D1 bone density case. For beginners, you will feel trouble during immediate installation in such a case. Okay, you need a sharp drill, and you must select a safe case. Okay, available apical bone must be more than 5 millimeter. Okay, for safe surgery. Okay. Here is another case, also 46 crown fracture case. Okay. What is the classification of this situation? okay, 46. Okay, crown fracture and apical lesion we can see. Again, look at my classification: type 1 sound socket, type 2 pathology socket, and depending on available apical bone height, from 5 millimeter more or less 5 millimeter, it is A or B. Then look at this case here. Let's trace mandibular canal and apical lesion here. This is bone destruction. So when you carefully evaluate this case, distal root belong to type 2B extraction socket, and the medial root belong to type 2A extraction socket. For clinicians with a limited experience, delayed implant placement would be safe choice in this situation. If approximately 4 months are allowed for healing, implant placement can be performed more easily and safely. Although I recognize that immediate implant would be somewhat challenging, I proceeded with the immediate implant placement after extraction in this case because I can use medial side. Okay, using a medial side is type 2A. Bone height is more than 5 millimeter, and tilt slightly distally. Maybe it's possible. Okay, here is clinical view. After the extraction, prepped osteotomy carefully with a long drill from medial root between medial and septal bone. And I checked the depth of osteotomy site. It is total 16 millimeter deep. Then here, X-thread 5 by 9.5 millimeter was placed. That time, only 5 millimeter X-thread was available. Okay, 15 Newton centimeter and 52. Safely, better to connect cover screw, but I prefer one-stage surgery. And in this case, the buccal bone is lost, so I decided to grab the bone at buccal side. I don't grab the total extraction socket. Instead, only at buccal side, I position graft material. Okay. Look at the depth of this implant. It is 7 millimeter deep. Okay. I connected a long healing abutment. Extraction itself is not so difficult. Remove the granulation tissue carefully. Already the hole is deep. Carefully advance the drill utilizing medial side. For 3.5, okay. Use depth gauge carefully to check the condition. This is 4.0 drill. And the last drill, 4.5. Then implant was placed. Okay, not bad. Deeply placed. Relatively weak ISQ value, but I decided to connect the healing abutment. Here I can see the grafting only at buccal side. At the graft connect the healing abutment. Okay, finish the surgery. Okay. Implant placed well at the center of socket. And this is a follow-up of healing 6 days, 1 month, 2 months. Look at the soft tissue healing and increase the ISQ value gradually. And 3 months, 1 week later, still ISQ value is not so high. However, Dr. Kim started a prosthetic procedure, and with a stock abutment, crown was fabricated. Here is the final outcome of this case. And 2 months and 3 weeks after delivering a final restoration. Okay, acceptable soft tissue condition and hard tissue condition you can see. Okay. Slightly buccal bone resorption occurred even I grafted the bone at the buccal side, but clinically it is acceptable situation. Okay, next is multiple case on the left mandibular molar side. Patient complained the pain with a fistula here. These are type 2 extraction socket, type 2A, but available one height is just 6 to 5 millimeter. For clinicians with a limited experience, it is not recommended immediate implant in this type of situation. It is not sufficiently safe. However, because I have considerable experience and because learning a dental practice has become increasingly challenging these days, I sometimes push the limit a little and attempt immediate implant placement after extraction. Well, this case, you can see the fistula on buccal side. It is partial endodontic treat condition and hopeless situation. How to extract tooth? I already shown you. The best is using a Cajon forceps. Okay, especially when it is furcation involved the case and sound crown. It's very nice device tool to extract tooth. After extraction, socket was cleaned using a dentist drill, prepped osteotomy 1 by 1. Number 36, I placed the XL implant 5 by 9.5. Okay, and then second hole was prepped. Because of bone density, I tried more drilling at that site. Another implant was placed. Okay, every implant looks nice stability, and especially number 36 buccal bone was gone. I decided to graft at this site. 37 is sound socket, buccal bone is sound, so I omit grafting at this site. Only 36 I grafted. Okay, and approximated flap simply. Cajon is really nice tool to extract molars. Always we feel trouble during the extraction. Okay, number 7, decide to sectioning the root. Let's speed up. After sectioning with a luxate elevator, I remove the roots. Then flat osteotomy one by one. Number 6 site positioned about 5 mm distal from the second premolar. Okay, depth gauge is my useful tool to make safe drilling. 4.0 drill was used. And 4.5 drill at last. Check the safety overhaul. Then X thread was placed. Okay, then I'll place another one. In such a trouble case, better to prep osteotomy one by one. In healed site, I prep osteotomy simultaneously to speed up, but not in such a hard case. With the tactile sense, gradually advance and check with the depth gauge. Always long drill, if possible, long is better than short drill. Bone was very dense at that site. I decided to prep sufficiently. One more XL implant was placed. Use good retractors during the implant surgery to make good surgical field and protect the soft tissue. I prefer using Minnesota retractor during the surgery. Don't hold the dental mirror when you do surgery. Okay, ISQ value was very nice. Then I decided to graft at first molar site because buccal bone was lost. I controlled the path of implant slide lingually. Intrasocket bone grafting was done at the buccal bone missing site. Usually, I don't open flap, but this case, it is detached spontaneously. That's why I need suturing for finishing. 5-0 nylon was used. After approximation, finish the surgery. Let your assistant hold the Minnesota retractor during suturing. Okay, then you can see nice surgical field. When your assistant hold the dental mirror, you cannot see such a good surgical field. Okay, done. Here POP, panoramic radiograph image, looks nice, implant positioning. And 7 days later, it placed deeply, especially anterior 6 implant. I changed the healing button to 7 mm long. 6 weeks later, look at the nice I-square value. And 2 months later, Dr. Kim started restoration. Recently, cementless type restoration is very popular. Dentists also supply good cementless restoration option. It is named Safe Fit. Okay, Dr. Kim connected the Safe Fit abutment and fabricated cementless crowns. Okay. After delivery, okay, it's in good condition. Okay, here final outcome. Okay, I will give answer about the last question. Yeah. What about utilizing granulation tissue during the immediate implant placement? Is it useful technique? In mandibular molar case, it is not useful. Typical to utilize granulation tissue. Some dentists like to utilize such a tissue during the ridge preservation, socket preservation, and delayed implant installation. But generally, it is not easy to utilize granulation tissue at mandibular molar site. And one more thing is, I don't prefer socket preservation. Okay, I just wait without grafting in delayed implant case. I will explain about my concept in the next webinar. And one more thing is that granulation tissue is useful in case of maxillary anterior case. When it is highly mobile anterior tooth and displaced tooth, which has soft tissue engagement around the socket, that situation, utilizing that granulation tissue is very useful. Okay, I can also explain how to use that kind of tissue during the third webinar. In my third webinar, I can show you the strategy of anterior maxillary implant. Okay? Okay, let me summarize today's lecture. When performing immediate implant placement after extraction in the mandibular posterior region, it is important to select the indications carefully. Cases should be selected in which implant placement can be performed safely and predictably. Okay, so my immediate implant indicates very narrow in reality. Drilling should be advanced gradually with a careful control of pressure, and the depths should be checked intermediately using a depth gauge. Okay, drilling gradually, checking with depth gauge is a really important technique. After drilling is completed, the osteotomy depth is measured, and the implant to be placed is selected. At this stage, the implant length should be chosen by calculating that the implant can be placed at least 5 mm deep from the buccal gingival margin. So, temporarily, we can imagine how long implant can be placed. However, actually, final decision should be made after measuring depth of your osteotomy site. For the gap between extraction socket and the implant, intrasocket bone grafting is performed when buccal bone loss is present. Okay, last, The XL implant is especially advantageous for immediate implant placement in the mandibular posterior region. Not only mandibular posterior region, XL implant is really good for immediate implant at any site. I can show you further discussion in the following webinars. Okay, it is time to finish the first webinar. I hope my presentation will be helpful to your clinical application. Thank you very much for your kind attention. See you next time.